that of suicide attempts for each completed suicide. Can you advance it? Okay, now the other two questions that we saw in there, which sex has the highest rate of completed suicides? I think most of you got that correct as well, and that is boys. And then which sex has the highest rate of suicide attempts? And again, I think that was correct in most of the responses, and that is in girls. So advance to the next slide. There we go. Again, here's some data from the CDC. If you look at the right side of the slide, you'll see, see the graph there. And might be a little hard to see, but if you'll look at the bottom two rows, there are some red arrows on the left. And the bottom two rows are, the rows are by age. So the lowest row there on the bottom is 10 to 14-year-old age group, and just above that is the 15 to 24-year-old age group. And the column up and down on the left, the kind of lighter blue represent the girls, and on the right, the darker blue are the boys. So you can see that in the very lowest age group, the ratio between boys and girls is 3 to 1, and overall the incidence there is quite low. So 1 per 100,000 in girls and 3 per 100,000 in boys. And then you go up to the 15 to 24-year age group, and you'll see that the incidence increases, and the ratio increases too, up to between 4 to 5 boys per girl ratio in that age group. Then, so overall, looking at the prevalence of suicidal ideation and attempts in females is higher than males. Although completed suicides is higher in male, the suicidal thoughts and attempts is higher in females. Overall, the ratio is 2 to 1. And during adolescence, after puberty, depression seems to increase in females and becomes twice as common in girls as in boys. So although girls are twice as likely to attempt suicide, boys actually account for almost 80% of all suicide-related deaths. At least that's been the accumulation in the past. And males overall choose the more lethal method of firearms, and females who complete suicide more often choose hanging or suffocation. And this graph shows some data in suicides by age group and by means in females and males. The graph on the left is females, the one on the right is males. And again, look at where the red arrows are, those two columns on the left in each graph there. And you'll see that the means are kind of color-coded. The darker color, pardon me? No, that's not the one. This is the one we should be on. Again, the two columns on the left in each slide represent the younger age group, the 10 to 14, and then the 15 to 24-year-old age group. And the means are color-coded. The firearms are the darkest blue on the bottom, and then slightly lighter blue is poisoning, which is usually overdose. And then the lighter kind of gray blue is suffocation or hanging, and then green is other. And you'll see that that in the lower age group, you have firearms and suffocation or hanging. And then if you look at the next older age group, you'll see that in the girls, the firearm is a smaller percentage, then there's some poisoning in the center, and then the larger portion there is the hanging and suffocation. And if you look at the graph on the right, again, the older age group, the teenage age group, they're the 15 to 24, the firearms now is significantly larger proportion. There's a small amount of poisoning or overdose, and then suffocation is also a fairly large proportion. So next slide. So that's the differences in the sexes there. So then there's a study that was recently published this year that looked, that reviewed suicides in youth age 10 to 19 between 1975 and 2016. And I think we'll go on to the next slide, which gives a better representation, a better way to look at this. So these graphs show the two age groups. The top graph is the 10 to 14-year-old age group, and the bottom is the 15 to 19-year-old. And on each graph, the top line, which is kind of a greenish, dark greenish color, represents male suicides, and the lighter yellow color is female suicides. And you'll notice that there's a large gap, especially around in the 90s and up to the early 2000s, to see how the number of suicides is much higher in the males and lower in the females. But if you look closer to around 2005, 2007, from then forward, that gap really narrows. So the distance between the two lines becomes much smaller. So beginning 2007 and on, the ratio between male to female has decreased. And especially if you notice the top graph, the younger kids, that gap has narrowed more in the younger children than it has in the teenagers. So let's go on to the next graph here. Oops. Okay, I have to go this way. Okay, and so they looked further in the study at the methods by male to female, and over time, the choice of overdose or poisoning remained pretty much the same. That didn't change much between the male and females. But again, as noted, the choice of hanging and suffocation is what really changed. And they found that the girls from 2000 forward were choosing hanging and suffocation at a much higher rate. That was increasing in the girls, but not in the boys. Then looking at the choice of firearms, males continue to increasingly choose firearms more as a method. So the ratio between male and females as far as firearms has actually increased. But overall, the biggest finding from the study was that the ratio between boys and girls is narrowing. The gap isn't as big, and the biggest difference was increased hanging and suffocation in the girls. Which, again, overall is a concern, because since girls attempt more than boys, if they are now beginning to choose more lethal means, that could be a consideration, concern. And this chart won't spend much time, but shows some trends in ethnicity. I don't know that the data is really strong, but there are some trends for higher rates being in certain ethnicities. So the highest is on top and decreases down as the list goes down. And this slide shows, again, it's another way of looking at the increasing suicide rates in youth over the years from 1999 to 2016. This is by state. The only state that did not have an increased rate is Nevada. The reasons for that aren't clearly known yet. They're looking at that. But if you look at Kansas, the rate actually went up by 45%, and in Missouri it was 36 point something %. So both states saw a definite increase. And here's some more data on Kansas. And most of the youth that suicided had previously talked about suicide. 66% had received mental health services, and 66% had some kind of family conflict just prior to the event. 44% left a suicide note, and 56% of the deaths were in males. 47% of the deaths were completed with a firearm. And this is a graph. This came from a study where they looked at gun ownership by state and in 2004, and then followed up by looking at completed suicides in youth age 17 and younger over a period of 10 years. And they found a positive correlation, a positive relationship between the amount of gun ownership and completed suicide rate. So it's a very positive straight line there. And I've got stars there so you can see where Kansas and Missouri fall on that line. And they also noted that about 80% of firearm-related suicides among youth involved a firearm that was owned by a household member.
So now I'm going to talk more specifically about risk factors for suicide completion. And first I'll talk about the predisposing factors. So the most important predisposing factor is psychiatric disorders. Studies show that 90% of people who commit suicide have at least one mental disorder. And most often it's depression. So that's 50 to 65% of the time it's depression. And that appears to be a factor, especially in females. Personality disorders are also a risk factor. 30 to 40% of these individuals have personality disorders or symptoms, and a borderline personality disorder and antisocial are common. Family history is important too, and from adoption studies, it appears that that's more of a genetic link rather than environmental, but both probably play a role. History of physical and sexual abuse is also important, and just kind of the environment that the child or adolescent is growing up in. So stresses like family death or parental issues in terms of separation of parents or psychiatric diagnosis in the parents, criminality or substance use in the parents, or financial strain, residential instability, all those play a role. Previous suicide attempt is also important, and that seems to be more of an effect for males. There have been a couple of studies we've looked at, but anywhere from 25 to 40% of people that complete suicide have had a previous attempt. And again, if a male has a suicide attempt, that's really a risk factor to be aware of. Next, I'm going to move on to precipitating factors. So alcohol and drug abuse are big. Alcohol can be disinhibiting, and it can precipitate suicide attempts and completion. Access to firearms is also important, and I'm sure they'll be discussing that in future talks in it as the slide that Dr. Cain just mentioned. But also acute loss and rejection. In the hospital, oftentimes we'll see patients who attempted suicide, and that seems to occur after a stress like a loss of a relationship or breakup with a boyfriend or a girlfriend. Social stress and isolation are important too, and along with depression, you see kids isolating and maybe not going out with a friend group as much, maybe not participating in groups and clubs as much. And there are some emotional and cognitive factors that are important too. So feelings of hopelessness, and especially children and adolescents that tend to be impulsive, can be a risk factor, and impaired problem solving. So those kids that have difficulty and they tend to be a little bit rigid or have some black and white thinking, that can be a problem. And then there's this thing called contagion, which really in the literature, they like the term imitation a little bit better, but it seems to account for about 5% of completed suicides. It appears to be more, not necessarily close friends and family members, but other people that can affect. And it's usually the person will maybe relate to something or be able to imitate something in the individual that completed suicide. And finally, I'm going to talk about some warning signs. And a lot of these are consistent with symptoms of depression too. So as I mentioned in the previous slide, loss of interest in pleasurable activities. So kids that maybe are stopping cheerleading or stopping volleyball or whatever activities they used to do. Neglect of personal appearance, feeling hopeless or helpless, those are symptoms of depression. And problems with sleep, so maybe sleeping too much and they show up late for school or not sleeping enough. Giving away belongings to friends is a warning sign. Obviously increased alcohol or drug use, because that again can disinhibit people, and they might be self-medicating. Any violent actions or changes in behavior or kind of conduct symptoms, especially if they're new, can be warning signs. So that's something to be aware of. And then expressing rage at others, and any sort of marked personality change. For instance, if someone's all of a sudden has sudden relief and their mood improves, sometimes that might mean that they have a plan in place, and that's something to be aware of. And finally, any sort of expression of a desire to die, whether that's on social media or a text message to someone else, that's a big warning sign and something that should be followed up on. And we've left you with some resources, and in the interest of time, maybe we'll move on.
Great.
Ma'am,
So
we
is there
have a
anything?
couple of questions.
Okay.
Okay.
Yes.
One
Yes.
that just came up most recently that I think a lot of people will find useful is the question about if you work with someone, a child that has precipitating factors and red flags, what steps should be taken? to
Right.
get intervened.
So I think that that's something that we're going to talk about in future sessions. So that's a really good question, and it's really important. So that's kind of what the future sessions will work on helping you with.
But we want to say, like, if someone has someone right now, I think being able to contact, perhaps depending on the situation, may need to go to the local emergency room. There's the suicide prevention lifeline that we'd like to make sure you have that number as well. If you have local mental health professionals you can contact, we certainly have resources here at our hospital that you can call into as well. I also just want to mention that Columbia Lighthouse Project 2 that you might want to check out. That website has some screening questions that are appropriate for really for anyone. There's some on there for designed for friends and family. There's some designed for teachers, for coaches, for police officers, for paramedics, for for really anyone that works with young people. So that might be something to search out as well. But I'll see if anyone else.
No, I think that's a great resource. And again, we will certainly get to this over the coming sessions. We just couldn't get to it all in today's session. So we had some really good questions though come in for Dr. Cain and Dr. Sharp. So I'm just going to ask a couple of those. Any idea what happened that contributed to the decline from 93 to 2005 was one of our questions.
I haven't seen a lot.
There weren't a lot of explanations of why and the
decline.
trends that we saw.
There were some thoughts about why the increase, but that's a good question about why the decline.
Did it intersect any of the medication?
Well, as I was going to say, I'd like to think it might have been about awareness for mental health, because there were more mental health services available and treatments during that time. I don't know if anyone's been able to.
Someone just
So
said
that
possibly the Brady Act, which I wonder if
And I will
that's
say,
played
I
into it.
Googled the Nevada has the decreasing rate, and I Googled why that might be, and they talked about an individual there who's sort of the suicide prevention coordinator for the state, and she's actually with teachers. They've required them to have suicide prevention training, and she's even worked with gun retailers to help them to be able to identify people at risk too. So it sounds like they have some really good programs they're setting in place there. So.
And then any idea why such a big increase for Kansas? Do we know?
No, it isn't just Kansas, but yeah, Kansas is really high. But I know some of the things that have been theorized for the increases in general are the difficulty with I think families not having as much time together, not as much communication, and social media, I think is one thought for that. But another one is gun ownership. States that tend to have higher gun ownership tend to be have the higher rates also.
Thank you. And the last one, which I'll just touch on because we're going to get to it next week, is what prevention curriculum are some schools using? And we have a great presentation next week with I'm on the camera now, with a school psychologist, head of the crisis team at one of our local school districts in Blue Valley, and they've actually created the school suicide prevention curriculum that is the model for the state of Kansas. So she's going to review that with everyone next week. So tune in next time for the answer to that wonderful question. And then I'm going to hand it over to Dr. Michael Lewis to share kind of about a pediatrician's role and kind of a case example.
And so, I really can't take any credit for a lot of the work that's actually been done here at KU. There's been a lot of focus actually very recently here on our campus. And somebody named Heidi Boehm has really been kind of at the forefront of really, I can't even begin to know how many hours and meetings and everything, and really probably a lot of myth busting as well, of going out there and talking about increasing the suicide screening that happens here. Because a lot of times, as we know, it's not necessarily a true organic reason of abdominal pain or a headache or something that maybe somebody comes to their provider for. The reality is that they're coming into our health system, for example, or anywhere with a complaint, and really that's just more of a symptom of maybe the bigger picture that is just mental health concerns, and we're just seeing it in psychosomatic ways, and trying to how we can identify those folks, as well as we know the people who have some sort of chronic needs as well, they have a higher risk, and so we're trying to get everyone under control and find out how do we identify all these people. And so some of the objectives for everybody, screening in the primary care setting, we're gonna, and then know your action plans ahead of time. And I think that's really been a big part of what we've tried to get some sort of grasp of what do we do once we screen for those kids. Because I think there's a significant amount of pushback in many communities, whether that's healthcare or wherever we're talking about where these kids interface with us. Once we have identified them, how do we help them? Because that's kind of, I think, a really crippling situation of, I have this kid right here in front of me and I know they are a very high risk kid. How do I help this family? And what do we do? Because identifying them is part of it, but we have to figure out how to get them into those resources. And I think everybody knows, unfortunately, there are not a lot of Dr. Cain. There is not a lot of Dr. Sharp. There's not a lot of Dr. Bellinger. And because of that, we, on those kind of identifying places, we need to know better how to also kind of do the first steps of management, I think, as well. And then also, we're going to review a case, and this is actually a case from just 2 weeks ago in my clinic. And I think really without a little bit of the infrastructure that we've put into place, even though we're still working on it, by definite means, we need a lot more work to help get a kid identified and into where I believe is the right place for him. And so I think a big part of the screening is yes, time is a factor. And we know that without
share your screen.
what's that?
Share your screen. No.
Okay.
Okay.
That I think that's probably one of the big things is that everybody, especially in the pediatrician's office or if it's a family physician's office, you only have so many minutes in those rooms, and who's doing those screenings, and then what kind of training do those people have it, and it takes time to do this right. And then there's a lot of different places that are like, well, we're getting audited for how well we're doing this type of screening. How well are we doing this type of screening? And a lot of the offices start to feel that stress. And I think you just have to simply start to figure out how do you advocate and get that to be an understood, very big part of each of these visits. And so it takes a real project leader to figure out where we're going to go with some of these screening tools. And there are a lot of them. And then also, this is kind of a similar link here on this slide that can take you and then and you can see a lot of these different screening tools. And so with that said, this is one of them. It's called the ASQ. And ultimately, it's not just identifying maybe, but maybe also trying to figure out how do we triage out these individuals. And okay, is this somebody who needs to be seen in the next 24 hours, needs to be seen urgently, or yes, we know that this is a patient who needs to be in with a mental health resource that we actually had no idea there was something going on. That's kind of part of what this also is starting to be triaging out. The ASQ is definitely one tool, and so here's some of the questions. And then here's another one. And actually, this is the one that is coming through with our health system. And the reason why is because of lower ages of validation, as well as there's what we call like a secondary. So once they maybe have had a positive screen, then we can start to triage them out of like a, whether it's a moderate, as a high, or a low. And with that said, every questionnaire is never going to be perfect. And I think that that's definitely something that we see probably with the comfort of the person who is administering it. If it's no different than, does anybody in the family have any heart disease? Does anybody have any family history of any asthma? And if they just bang through those questions really quickly without any focus and actual intent of how they're asking and making some eye contact, I think that you're not going to have near the success of truly getting people to think about some of these questions. And I think that's a big, big part of some of the topics that we've heard about. And so like I said, we know that there is definitely a gap because there's just not enough pediatric mental health resources out there. I think everybody here today would all agree with that, and that's why we're talking to everyone here. And how do we not be all in the community become content experts, but how do we help understand some of the people who aren't right now on this call and this presentation? How do we help those take on our belief and really move out and get them to maybe those of you who are on the this call and the presentation? So you might be the content expert in your community and really know where to direct these kids. And I think what makes it the most difficult is what happens in one school is not going to necessarily be what happens in another school. What happens in one community health center is not necessarily going to be what happens in another community health center or emergency room. We have access, Dr. Cain's team, they also run an inpatient psychiatric hospital. It's actually the largest standalone pediatric hospital in the state of Kansas. I think that's an amazingly telling thing when our largest standing pediatric hospital in the state of Kansas is psychiatric. That I think identifies that there's a huge need, and I know that there's even more needs out there than even what everyone's able to address. And so it's a lot of partnerships. And I think that whether it is the mental health providers in the community, going to the schools, going to the coaches, the Little League coaches, those are all areas that kids are interfacing with people who can help identify them. And how do we then direct them? Because if it's 6 o'clock at night and a kid is in soccer practice and says to the coach says, "How you doing?" And he says, "Terrible," and starts crying and saying, "I'm thinking about hurting myself." That coach is going to be pretty paralyzed unless we do our job of trying to empower them and give them the tools of how to talk to those kids in the moment, as well as make sure that the parent is engaged and we get that kid the help that they need. So here's a kid that actually came to my clinic. And I kind of had a heads up because he was an overbooked patient, and it had like an exclamation point that mom wanted to be seen today. And so it was a 10-year-old boy, and he came in for the chief complaint of really ADHD, and he had mostly inattentive symptoms, and it was for a follow-up. He was on a low dose of Adderall, 5 milligrams, and mom said it wasn't working well. We'd been on it for a few years. He's had a lot of weight gain in the last couple of years, so it was understandable probably why this wasn't working anymore. He was extremely anxious during that exam. And even though it's now starting to cool, a few weeks ago, it was definitely not very cool out there, and he had long sleeves on. And this is kind of one of the things that I've always done in my practice with the emergence of self-harm with cutting is I always try to feel the pulse. At least that's what I say is I am feeling for the pulse, but I always try to look at the forearms of these kids. Kids are doing that, and I think that it's an evolution. And now there's a lot more cutting that's happening on their thighs because I think that they want to try to hide their cutting even more. But by wearing pants, they're a little bit more capable of hiding some of that when they come to the visits. But this is a kid who definitely had some cutting on his left forearm. I can't begin to think of the number of times I've been told that it's a new cat at home that has done this to a kid's arm. And those lines are far too straight and too evenly spaced to definitely be a cat. So I just say to everybody, if you see that, please don't just take that first excuse. If it doesn't smell right, please keep digging, because those are just some of those warning signs that we know these kids are self-harming a lot now. And so a little bit of past history really about this kid to set a little bit more of the scene. It's a single mom, and there's 2 older boys, and I was actually the primary care provider for each of them. And the middle kiddo, he was transgender, and his JP had told me years in advance that he was homosexual and wanted to eventually transition. And we talked a lot about that and how he was going to go about when he wanted to do this process. And eventually, kind of on a whim, he was angry one night and just told his mom. And probably one of the worst reactions that I can imagine was what happened here. is that the mom called her father in Peru, and he moved to the United States. And so then JP came to a visit, and there was a grandfather there. And I asked, well, why? Oh, hi, nice to meet you. And in front of the boy too, I asked, oh, so you're here visiting? And the grandfather goes, no, I've moved to get the gay out of JP. And just see the reaction that happened in that room. I mean, you can't really replicate just how bad that was. And the grandfather lived there for a few years. And so the patient that I was seeing that day, he had had years of really just toxic stress about his siblings' homosexuality. And what happened is I can sense that the boy was really anxious that day. And I asked him, I go, something wrong, after I noticed he had cutting. And he says to me, I regret myself being alive. And so at a kid this age, the ability for them to say, yeah, I'm having suicidal ideations is obviously not going to maybe be there. But I had at least a sense that there was something definitely going on, and he became very emotional. And mom started sobbing. He started sobbing. And I asked mom to step out of the room for a second and just talk to him, since I'd known him for a long time. And we downplayed things a little bit. And I said to his mom, who had actually not been the biggest advocate for mental health in general, I think we need to have a social worker come in and talk to him. And so our social worker, who was in our clinic, came in and actually administered the screening, and he was definitely a very high risk. And so from there, we sent him, we knew that he needed inpatient psychiatric admission. And even here in Kansas City, where I think we have a fair number of beds, but definitely not enough, there was no open bed in any inpatient facility at that time. So then he went to here at KU to our pediatric hospital team, and we had a constant observer with him. And then the next day, it was time, there was a bed that opened up to get him transferred. And even at that point, the mom started to get a little bit of cold feet for that hospitalization, because usually we see a lot of these kids, if there's not an immediate bed, suddenly 24 hours in a medical bed of just having a constant observer, the kid starts to change maybe a little bit of their thoughts out loud, but we know that they're not definitely changing. So I actually got called, and I came back up and talked to the family and advocated again for the hospitalization. And so I think that's just a good example of, if we have some built-in infrastructure of how to identify at the front line and then make sure who that next step is. So for me that day, it was clearly the social worker who could jump in and administer that screening, and then we could get that kid to the right place. And he's doing well right now. But I think it just goes to show that these kids can come for various reasons to whatever we're going to be front-facing with them. And if by having some sort of approach, then we know where in each of our communities how to get these kids the most immediate care they need. So thank you. And I think now is time for some questions.
Yes, looks like we have some good questions. Are we gonna just turn the camera back on? Okay. Looks like there was a comment from Donna Glover. She says, sometimes with younger students, it's difficult to get parents to understand that a child is truly asking for help. So I don't know if you've had any success with kind of getting parents to understand that it's a real concern.
Well, I think all of us, Drs. Cain, Sharp, and myself, could agree that we've seen kids who have tried to hurt themselves at very, very young ages. And I just give personal examples of things that I've seen to families and said, this is your kid at risk. We know your kid is at risk. And things are not getting better. And we just want to help you. And just continuing spending the time, I think, is the best way of educating them. But mental health is not always the most easily talked about thing with families who have a kid at risk.
That's true. The other thing I'd add, I noticed that your patient was 10, came around the border, and I mentioned earlier that suicide is very rare in the youngest children, but and they do sometimes suicide in young children, as you saw in the data, although it isn't common, it does happen. And when it does, oftentimes they have ADHD or impulsive behaviors. And the thing about with young children, that sometimes they can have suicidal thoughts. And I think it is sometimes tough to involve parents, and we spend time trying to educate them and let them know that sometimes with young children, they can truly have that sadness and that, or with anger, impulsivity, and really have an intent to die. They just may not know or understand the ways to do it. So sometimes their thoughts and plans may not sound realistic to adults. So because of that, adults may not take them seriously, but they really need to, because that intent can be there. And so I think it really needs to be paid attention to.
I think that impulsivity piece is also really important
Yes.
to remember as well.
Well, it's the impulsivity piece. And then I also think that at younger ages, they don't really truly recognize the finality
Exactly.
of a decision. And that's another thing that I think to say to families, like, your kid doesn't even really understand what they're saying, but that doesn't mean that they may not try something that's going to hurt themselves. Because this may not be just a reaching out and I'm going to take one Tylenol tab to hurt myself. They may truly do something that we can't go back and change.
Right. And they often don't understand how dangerous Tylenol can be, or
Sure.
Advil. They think things that
Yes.
you can get over the counter, things you can get in the store, are not that dangerous.
I think with kids with ADHD, we often see bullying in some of those components in their social world. So I think what you said earlier about that is so important.
Sorry, we're
People's
switching,
preconceptions
switching the
about-
camera a lot.
about mental health in general. Sometimes it's nice to kind of tease that out a little bit too in families if they're hesitant to maybe admit, maybe they have a family story, their uncle was admitted or had a bad experience with mental health. And so sometimes trying to kind of reassure them a little bit about, things have changed and, all of the resources available and that kind of thing can help.
Another question for Dr. Lewis, I think, is do you screen patients at every visit? And this is probably an interesting question.
Right now, it's not happening at every visit. There's definitely work in progress to be getting each of these kids screened at every visit in the outpatient setting. In the inpatient setting, they're getting screened, but outpatient right now, it is not every single screening, but it's going to be happening because we know, like I said, for an acute headache or something else, there could be that might actually just be their way to come and see somebody.
Mm-hmm. Absolutely. Another question, and I don't know if you have the answer to this, but question from Donna Glover, what can we do to help with cutting? This is one area where I feel hopeless.
I'm going to defer to the mental health specialist on that.
Well, I mean, ideally they should have a therapist, and sometimes that's difficult, but talking about coping skills. So what can they do? They usually cut because it gives some sort of release, or it's their way of coping. And so trying to replace that with something else that's more healthy, whether that's deep breathing or listening to music or petting the family pet or reaching out to a friend or, whatever might be available to them. And again, that's not something that's going to work right away. Typically, these kids have been cutting for a while. And so it takes a little time to get them over that. But working closely with a therapist on working on those coping skills is a start.
We had some great questions. I don't know if we were able to get to them all, but we got to a lot of them today. We really want to get you out on time, but we really want to thank you all for being here today. And we really would like you to join us. We'd like you to join us next week, where I mentioned that we're going to be talking about more in depth about screening and risk assessment and safety planning. So more of that, what to do. This was kind of what's the problem, but we definitely want to give you some concrete answers about tools to use for screening and risk assessment and safety planning to really keep kids safe. And again, we're also going to hear from a Kansas City area school district and talk about, they have a really comprehensive plan that starts from kind of like a happiness project and just resilience and goes all the way through to follow up after hospitalization, which I think is a really important topic that sometimes we think that it's once they've been hospitalized, then they're fine and, kind of go back to life as usual. And that really isn't the case. So they have a great plan for that as well. So again, we're really looking forward to having you to join us next week and throughout the series. Again, we would love some more community examples from our more rural communities and all over Kansas. So if you have some great examples of how you work together as a community, a school district, a mental health center, health centers, anything that of how you kind of have come together as a community and created a comprehensive plan to help keep kids safe. We would love to hear that from you, and we'd love to highlight you and have you present as kind of one of our community examples in future sessions. So please email the Telehealth Rocks email if you have some examples of that, or if you have a community that really is struggling to put one together and you would like us to kind of talk through that together, we could definitely do that as well too, if you had some people that were willing to be on the hot seat and kind of talk through what some ideas would be to address that. So again, we really want to thank you for joining us today. And I think we'll kind of let you go right at 1 p.m. and make sure you respond to those evaluations that we send so that you can get your CME credit and we can kind of get your feedback. So thanks again, and we'll see you next week.